Up next, we have Dr. Harmath from the University of Chicago. She's an associate professor of radiology at U Chicago and chief of the section of abdominal imaging. Her research interests include oncologic imaging, transplant imaging, and novel imaging technologies. One of her main professional goals is collaborative approach to teaching and patient care with full engagement of the professional team and patient. She's going to be talking about best imaging modality for appendix cancer. She's going to be coming on, and then shortly after, we will begin the nutrition and QOL roundtable around 1:50. So please stay tuned for that. And I'm going to open up for Dr. Harmath. Thanks.
All right. Hi, good morning, everyone. Welcome. I was asked to discuss the best imaging modalities for appendiceal cancer, being CT, MR, or PET. So let's go through it quickly. We have just to remember that there are different types of neoplasm that involve the appendix, and we generally distribute it or classify it into mucinous and non-mucinous tumors for our diagnosis and for the workup. Most appendiceal neoplasms like to spread in the peritoneal cavity, and that can be challenging for us as radiologists and imagers. The peritoneum is this thin membrane that surrounds every organ and lines the interior wall of the abdominal cavity, and is less than 1 millimeter thick, so it can be very challenging to visualize it in imaging. So just a few examples on how metastatic appendiceal cancer can look. On the left-hand side here, we have a mucinous tumor, which basically looks like fluid containing lesions around the organs, and they're delineated by those arrowheads. On the right-hand side, we have more solid-looking tumors also pointed with the arrowheads, and those have more of what we call a soft tissue characteristic, meaning they're not fluid-looking. They look more like cells and the other tissues in organs or muscles, for example, that we can see surrounding the body wall. So those have different ways that they look like in imaging and different ways that they react. And that can be challenging to image, because the mucinous tumors usually are not going to have what we call enhancement or activity on PET unless they have a solid component. The solid tumors, on the other hand, they will show what we call enhancement after contrast, and they will have usually some activity on the PET exam. So what exam is best? It's going to depend on the patient, and it's going to depend on the type of tumor. This is an MRI showing how tumors can look like, and this is a tumor that has more solid components. And on the MRI, these areas pointed out by the arrowheads are actually the solid components of a tumor. There are several different what we call sequences in MRI, and that's why patients do spend a larger amount of time in an MRI scanner than a CT scanner, because we're acquiring different ways that things look. For example, this one that I'm showing now is what we call a T1 image, and that is an image that we use after contrast and pre-contrast to look at the solid components that are enhancing. Now, this other image that I'm showing is what we call a T2 image, and that is sensitive to fluid or fluid-like structures. So this is showing here an appendix that is abnormal with fluid, but also shows a little bit of the bladder with fluid and some small bowel loops with fluid. So with MR, we need these different sequences to show and characterize a lesion, whereas with CT, it's mostly contrast or non-contrast. There are not that many different sequences or phases. Moving on to a PET exam. So a PET exam is an exam that does involve radiation, but we use glucose that is bound with a radiopharmaceutical in order to see that activity. So solid tumors are cells that are multiplying, for example, they need a lot of glucose. So they're going to uptake this glucose that is bound to the radiopharmaceutical, and then they're going to show activity like we see here on this exam. So this is the CT part that goes with the PET exam. The PET exam shows this brighter areas, bright orange or yellow here. These are the tumors that are active, depicted here by just these areas that are not very well defined on the CT exam. So you can see that different exams have different appearance, and different tumors have different characteristics that are better seen in one or another imaging modality. Also, just to take into consideration, our own body habit is really is a little bit tricky, because some people that have more intra-abdominal fat make these structures a little bit more contrasty on a CT exam. So I have bowel here, and then I have the peritoneal fat. That really makes it easier for me to see this abnormality here involving the cecum, where the appendix is. However, in a patient that has less intra-abdominal fat, everything overlaps a little bit. You see the muscles closer, there's less of that fat that promotes that contrast, and it can be a little bit harder to see subtle tumors, especially along the bowel wall. So let's go briefly over every modality and talk about a little bit of the pros and cons. So this is contrasting hand CT. The pros is that, it does have a superior spatial resolution, meaning, the little structures close to each other can be well depicted. It's fast. We can be in and out in like 5 minutes. It's readily available. So a lot of places have it, and most places are very consistent in terms of the quality. So it's very reproducible. So whatever you get a CT imaging, most of places are going to have the similar quality. The cons is that the sensitivity is about 11% for lesions less than 5 millimeters, but still they can be seen. And it can be very difficult to distinguish a thin tumor sheet, especially in the peritoneum, from normal peritoneal lining. Sometimes the peritoneum gets thickened by other things like inflammation or even post-operative changes and fibrosis, and that makes it very difficult in any imaging modality to distinguish tumor from the normal structure. A PET FDG, which is the one with glucose, it does localize malignant tissue by increased tracer uptake. However, anything that is acting fast or reproducing or replicating fast, like cells that are active, may show activity. So we have to know which areas are normally showing activity versus which areas are going to be tumor. The cons is that small volumes or thin tumors may not create enough activity for us to be able to see them with a PET. If it's not a solid metastasis, like in the cases of mucinous tumors, for example, mucin is not going to produce enough activity because the cells that are producing mucin are the ones that are active, and sometimes they're very small. They produce a lot of mucin, which is that gelatinous fluid looking like structure, but they are not active on the PET. So that can be tricky to image with FDG PET. Again, if not a solid metastasis, it may not have enough activity, and certain tumors themselves do not produce or replicate very fast to promote enough activity for us to see on PET. And lastly, MRI. This is a specific sequence that we call diffusion-weighted sequence, which is basically a sequence that is sensitive to the motion of fluid within a lesion. And it takes into consideration that most tumors are very packed in cells, very tightly packed, so they don't let the fluid move around. And this will restrict the diffusion of fluid. So this is how these would look like on diffusion-weighted imaging MRI. So it does have a high per patient sensitivity because the tumors will look generally bright. But per lesion sensitivity is about 20% because it's very difficult to distinguish some motion artifact and fluid in bowel sometimes from these areas of activity. Lesions that are less than 3 to 5 millimeters will be very difficult to see, especially if they're adjacent to bowel or fat or air-containing structures. The peristalsis, which is the bowel movement and bowel gas, will promote artifact on MRI, which can limit the visualization. And again, mucinous tumors are going to be fluid-looking, so they will not really restrict the diffusion of fluid, and they can look just like fluid. So that may be difficult to distinguish from, just routine fluid or post-operative fluid on MRI. So just for the future, we're working together with our team here at University of Chicago, and we are trying to get better ways of imaging peritoneal tumor in general. And with the help of our patients, we've been developing higher resolution MR imaging, trying to outline the wall of the bowel, the exterior wall, which in this case, for example, is very thick in the peritoneal lining and the wall of the bowel in the surface where the peritoneal lining is covering it. And we're developing the sequence to try and distinguish very early tumor involvement in the peritoneum. And this is, the intraoperative appearance that the surgeon saw after we saw this peritoneal lining thickening. Similarly, here we have this very subtle areas that are, demonstrating the peritoneal lining thickening. And when the surgeon went in, that's what they see in terms of the tumor presence. So just some take-home points. Different types of tumor may benefit from different imaging modalities. So it all depends on what type of tumor you have. And also different patients may benefit from different modalities. It all depends on our body habitus and how the tumor is presenting. Even the same patient at different points in time may benefit from different modalities of imaging of the tumor. So it's not a one size fits all, and we have to really try and personalize medicine to all of our patients. So discussing it with the surgeon, discussing it with the radiologist, and having a team approach to the imaging of appendiceal cancer is the key. And I appreciate your presence and participation. I'll be free to answer questions later on this session today. Thank you.